Now that you're familiar with the case, let's take a closer look at it. I think the key takeaway point from this case study is that not all patients with celiac disease will present with typical gastrointestinal manifestations. And in fact, some patients will never have gut symptoms through the whole course of their disease. So if you see a patient with an incidental finding such as this, with osteoporosis, some form of nutritional deficiency, or a skin-related concern, keep celiac disease in the back of your mind because it is a very common disease. Currently, the recommended serological screening test for celiac disease is the IgA tissue transglutaminase antibody, and that's because it has very high diagnostic sensitivity and specificity, with a sensitivity of greater than 90% in our population. However, it can be falsely negative, for example, in IgA deficient patients or in patients who are following gluten-free diet. So it's important to also test for a total serum IgA or an IgG deaminated gliadin peptide antibody at the same time. In this context, it's important to remember that these tests are not perfect. There is about a 10 or 15% falsely negative rate, and that might occur in patients who are IgA deficient if you're only using an IgA-based serological screening test. Infants can sometimes have poor IgA responses, so it's important to use an IgG serological screening test, and ideally hold off on serological screening until the child is, say, 4 years old. Patients who are on a gluten-free diet will often have falsely negative screening tests, as well as patients who are heavily immunosuppressed. There's also always the possibility of a laboratory error. So if there is a strong clinical suspicion, repeat testing on a gluten-rich diet may be worthwhile. IgA deficiency and celiac disease are very strongly associated. Approximately 2 to 3% of patients with celiac disease will have IgA deficiency, and IgA deficient individuals are 10 to 20 times more likely to develop celiac disease. So it's important to remember when you're screening patients for celiac disease that IgA deficiency is a possibility. And if you have an individual who's IgA deficient, it's worthwhile screening them for celiac disease as well as celiac genotype to understand if they're likely to go on to develop celiac disease. Also important to remember that IgA-based serological tests will be falsely negative in IgA deficient individuals. I think the most important thing to remember here is that you cannot establish a diagnosis of celiac disease using genetic testing, but it is a very powerful test of exclusion of celiac disease. Up to 99.6% of patients will express HLA-DQ2 or DQ8, so if your patient doesn't have either of those, then you can effectively exclude a diagnosis of celiac disease. If the gene test is positive, however, it's important to remember that only 1 in 30 patients with a positive gene will go on to develop celiac disease. It can be useful in some clinical scenarios, for example, if the serological tests are equivocal or ambivalent, if the serological tests don't match with the biopsy findings, or if your patient is on a gluten-free diet and doesn't want to resume gluten consumption, you can use the celiac gene test to exclude celiac disease if it's negative. Celiac gene testing can also be used to screen at-risk individuals, for example, family members of patients with celiac disease or at-risk individuals such as Down syndrome, Turner syndrome, and IgA deficiency. It also has a role in non-biopsy diagnosis in children, according to the SBAN guidelines. This case is a good illustration of an atypical presentation of celiac disease and a reminder of the strong association between celiac disease and IgA deficiency, as well as the diagnostic challenge that this association poses. It also demonstrates that an appropriate diagnostic algorithm utilizing highly sensitive and specific tests is essential for screening for celiac disease. Thanks for watching.